In part 2 of the simulation lab video, we will be looking at the features of the new Laerdal SimFamily, which includes SimMom, SimJunior, and SimBaby. These high-fidelity simulators greatly expand our ability to train and test among a diverse patient population. We here in the Access system wish to set you up for success and make the SimLab experience more realistic and impactful. Hello friends and EMS professionals, Stephen Sioni here, training captain for Ada County Paramedics. Whether you are here preparing for Phase 4 testing with the medical director, or going through practical testing as a potential new hire, we would like to introduce you to the rest of the Sim family. Starting with SimMom, let's review some of the cool new features. Your general impression may start with any combination of sounds, such as shortness of breath, moaning, vomiting, or other. As you start to assess the ABCDs, note any issues with the airway to include potential airway swelling, or maybe cyanosis as indicated by blue lights inside the mouth. As always, we want airway patency and protection, so please manage accordingly. The simulator will breathe spontaneously at a selected rate, so take a moment to properly assess. The chest will rise and fall to match the rate and breath sounds. Lung sounds can be heard with a stethoscope through speakers located on the chest and the mid-axillary sites. We can also use an auscultation focus to eliminate the mechanical sounds of the simulator to better allow the provider to hear the nuances of wheezes, rales, or rhonchi, for example. This may temporarily cease the rise and fall of the chest, but don't be fooled. If the patient is still talking, then the patient is certainly still breathing. The airway can be properly managed by any number of BLS or ALS procedures to include head tilt chin lift, jaw thrust, or other positioning. OPAs, MPAs, CPAP, supraglottic airways, nasal, and even endotracheal intubation are all accepted. Please don't ask if the patient accepts an airway. Just attempt to place it and you will quickly find out. If properly treated, the simulator will respond to chest rise and fall along with sensors that tell the proctor the simulator is being properly ventilated. As a testing tip, this new SimMom can also demonstrate airway obstruction or airway edema, which may likely guide your treatment. Important note here, if the laryngoscope blade or the LMA won't fit, please do not force it. It is part of the scenario and therefore requires an alternative approach. These simulators are expensive and we want them to last. It can also demonstrate the one-sided absent lung sounds and asymmetric chest rise of a tension pneumo, which might require a needle decompression, if the midclavicular or mid-axillary regions are both in play. If you encounter a can't ventilate, can't intubate situation, you should ask yourself if a surgical cricothyrotomy is indicated. As for circulation, bilateral pulses at the carotid and the right radial sites can be activated with slight pressure and a slow release. Please understand the location of the radial pulse, and pulse locations must be soft. Pulses cannot be felt over hard plastic locations. It's perfectly acceptable to ask your partner to verify the presence of pulses after or while you are checking. The pulses may disappear with decreased blood pressure or in cardiac arrest. Manual blood pressures on the right arm only. SimMom cannot display desired skin signs, so you would need to assess those through questioning. In terms of disability, the pupil size can be changed out prior to the start of the scenario, but no pupil response to light or eyelid blinking like in the SimMan 3G+. SimMom is capable of seizures at various levels of intensity. This simulator can also urinate or bleed vaginally if the scenario calls for it. The vital signs such as heart rate, blood pressure, pulse oximeter, and the 4-lead EKG will show up on the wall monitor once applied. If end-tidal CO2 is placed on the patient, then a respiratory rate and capnography will display on the wall monitor. Only the heart rate and rhythm will also appear on the Zoll monitor. Please refer to the wall screen as the most accurate set of vital signs. Rhythm identification and electrical therapy. There are 4-lead cable posts on the torso. If a 12-lead is requested, then it'll show up on the wall screen, but not on the Zoll X series. There are no EKG cable posts for the 12-lead, so please do not stick electrodes on the simulator, as the actual 12-lead application will be simulated. We will use combination electrical therapy posts for transcutaneous pacing, synchronized cardioversion, and defibrillation. If done properly, pacing will capture both electrically and manually on the wall as well as on the X series Zoll. IV and medications. The simulator has bilateral IV ports at the forearms, which quickly connect to an extension set or a saline lock without having to use an IV catheter. Please use Coban to secure and avoid transport or other types of tape because the Laerdal SimFamily is, well, basically allergic. Please do not push any type of medications or IV fluids through the simulator, as this step will be verbalized and noted by the proctors when given. Small volume IM injections are okay at the bilateral deltoids and the bilateral thighs at the vastus lateralis. Sorry friends, but no IOs on SimMom. This mannequin's body and extremities move and articulate more than any of its predecessors, allowing for easier assessments and more realism. The mannequin can be moved to whatever position you feel is necessary. This includes common birthing positions or even the knee to chest position. Please use care and caution as you would with a real person. Just like in real life, please coordinate patient movement plan with your partner to avoid any type of lifting injuries. With this degree of high fidelity, most things are as you find them. Whether in training or testing, for example, if you ask, what is the patient's breathing rate? Or what are the patient's pulses like? The response from the proctor will likely be, as you find them, leading you to further assess your patient. Seek information from the patient as opposed to the proctor. Remember, SimMom may have a wide variety of pregnancy-related problems, ranging from early to late trimester bleeding, from normal to complicated deliveries, or even a wide variety of other medical issues. Please assess all patients thoroughly and treat all life threats aggressively. Let's take a look at Sim Junior and Sim Baby. These kids don't have quite the level of high fidelity as SimMom and SimMan, but they're neat little simulators. Both have fully interactive airway that can be managed through all the same BLS and ALS maneuvers except for surgical and needle cricothyrotomy. Don't hold back on airway assessment or management if the situation calls for it. Both pediatric simulators can breathe at set rates with corresponding chest rise and fall and anterior lung auscultation sites. With circulation, in both simulators we have carotid, brachial, and radial pulses that also correspond with decreasing blood pressures. Both simulators operate similar to SimMom when it comes to cardiac EKG monitoring and electrical therapy. You will use the EKG posts for 4-lead monitoring and electrical therapy posts, not the combination adhesive pads. Both Sim Junior and Sim Baby can accept IVs at the right arm and hand, as well as IOs on the right leg at the tibial tuberosity. And seizure history must be genetic because all the simulators are capable of seizure activity. Sim Baby has a few extra cool features. Like SimMan 3G+, Sim Baby can have eyes open, eyes half open, or eyes closed. Sim Baby can exhibit arm movement or limp tone, bulging fontanelles, abdominal distension, even capillary refill on the left palm and the proximal sternum. Sim Baby has a femoral pulse, which are the most central and therefore the most accurate. Pro tip: find the opportunity to conduct thorough physical exams and even repeat exams for the signs and symptoms that may change or fit into your working diagnosis. How else will you know if your treatments are effective? Check your patient and verbalize the findings prior to asking the proctor for changes in patient status. What is it exactly that you are hoping improves? Continue to ask your patient how they're feeling and continue to assess for adequate breathing. So let's talk equipment. We use the Zoll X-Series cardiac monitor. So if you're not familiar, please take the time to become familiar and/or watch a video on its basic functions. EMTs and advanced providers will not be expected to interpret EKGs or use the ALS functions that would be outside their scope of practice. EMTs will be expected to operate an AED. We use the Zoll AED3, which operates much like any other AED. In addition to the monitor, we have 3 blue equipment bags. The royal blue bag will have a mixture of BLS and ALS equipment, while the navy blue bag is predominantly ALS equipment. A third pediatric bag includes a length-based tape for equipment recommendations and medication dosages. It's broken down by color, which corresponds to a same colored equipment pouch. This is a super helpful tool, so I advise you take a look and use it early in your pediatric calls. There's also an OB kit, along with other various pieces of PD and OB equipment. Please ask your partner to help if you cannot locate a specific piece of equipment, or if we do not carry it, verbalize how you would use it. If you are in the sim lab on behalf of your fire department, please request training equipment from your respective training captain. Hey, I get it. It's a lot to remember. Let's put technology aside for a minute and talk strategy. Here are some training techniques that will help you better understand the simulation process. First, treat the scenario like a real call. Talk to your patient as you would in real life. Interact with any bystanders, real or imaginary, by asking a comprehensive set of questions to help you develop an accurate history of the event. Don't forget to conduct a physical exam as necessary. A good assessment trumps individual provider skills. We want to know if you can determine a working diagnosis from your assessment and you can run the call from start to finish. You are being evaluated on everything from assessments to treatment, from scene management to radio report, and from patient interactions to team delegation, and possibly a few other things in between. Secondly, assume everything happens in real time unless told otherwise. For example, if you use a medication with a 3-minute onset, don't expect an immediate response. The scenario will run the full duration, so don't expect them to end early. Instead, continue to assess or interact or make your patient comfortable. Pay attention and inquire about scene clues or simulation props. Thirdly, be courteous to your patient and partners, and delegate those tasks accordingly. EMS is a team sport and you cannot do it all efficiently by yourself. Additionally, there are limitations of simulation, and although the lifelike features have come a long way and these new simulators can do a lot, they cannot change skin color to reflect pale, ashen, or flushed. The simulator cannot use a combination of accessory muscles when struggling to breathe, or display the classic look and facial expressions of fear and distress. These things must be evaluated by asking. Ask the proctor questions to answers that the simulator cannot provide. This will help you navigate the scenario and help put you on the right path. If you are visually or physically assessing the mannequin, verbally state those findings. This shows the evaluators how thorough you are. Remember, we cannot read your mind and nothing is assumed. And lastly, please try to enjoy the process. We're not trying to jam you up, but more like trying to make you better. Testing is confidential, and what happens in the sim lab is only discussed with the evaluators and the training staff. Remember to relax and be yourself, as communication and compassion are important aspects to the job. And with that, I look forward to training with you.
Hey, what's up, y'all? I'm Emily. Welcome to my crib. No, for real, welcome to my crib. This is my sister Sarah. She's a Giants fan. Boo! That's why she's such a dummy. As for me, I'm a Mets fan.